Topic today is going to be talking about a new tool that we are going to discuss a little bit more in detail, but I will start out with a specific patient population that will really greatly benefit from it, okay? These are our drug-resistant epilepsy patients, and just tell you a little bit about me. I am an epilepsy specialist. I work at the Kaiser Permanente facility in Northern California, Redwood City. I know there is Kaiser facilities here all over California. I have worked here as well, but the MEG we do have in Northern California, and so I'm here to tell you about that. All right. I have no disclosures, and I would like to start out with a patient example, as you all can probably feel into it. My young patient, a young woman, age 26, came to me in 2018 with some spells of unclear where they're coming from, not clear if they're even seizures. The family is describing, sudden change of awareness, not responding. She's kind of out there. She would come back from the seizures and she would not remember them. She would sometimes tell us, I have this strange sensation in the epigastric area. I have some auditory hallucinations, and occasionally I would pass out, and then there's some shaking. So she has no epilepsy risk factors, no family history. It just kind of came out of the blue. We did an EEG on her, which was abnormal, showing that there's probably something wrong in the left side of her temporal area. Her MRI of the brain confirms that and showed some mid-temporal region abnormalities. She was started on medication, first with the levetiracetam, and her seizures got better, but they continued. Finally, towards the mid of 2018, she was admitted to the hospital for monitoring. We call it epilepsy monitoring unit. And so she came in, stayed with us for 5 days. We captured 5 of her typical seizure events, which you can see here, a little rhythmicity up there on the very top, and down there at the bottom you can see some epileptiform discharges. So she clearly had seizures, that was clear. We diagnosed that. It looks like it's coming from a focus from one area of the brain, the left temporal area. So we continued with a workup. We got a PET scan, which showed some abnormality, neuropsychological evaluation, fMRI. At that point, she already needed a second medication. And even with the second medication, she was having breakthrough seizures, about 4 to 5 per week, which really greatly impacted her life. So we moved on, we discussed her on the epilepsy surgery conference, and we decided to dig into her brain a little bit more in detail. So we put some electrodes directly into the brain, and we captured about 15 seizures. And all of them were coming from one area, and one area was the mesial hippocampus on the left side. So we decided to offer her a surgical approach and remove the mesial structures as well as her lesion. And thank goodness she's seizure-free. See, she's seizure-free for 3 years now, is very happy. She still takes some of her medications. She has her goals. She wants to finish her training as a paramedic and help others. She's very vocal about her condition and is really an impressive individual. Now you can see the MRI here on the left side is the one pre-surgery. On the right side you can see the post-surgical changes with these hole in there. So this is what was removed. So she's one of these examples of our what we call drug-resistant epilepsy patients, right? These are patients who do not respond despite being on 2 seizures, going up on the dose, taking it diligently, they still continue having seizures. So this is our most vulnerable population in our epilepsy world. There are many of them, about 40% of our epilepsy patients, so out of 3.4 million, about 1 million are the patients that do not respond to medications. And important is to know that we define that. So if the patient does not respond to an adequate trial of a second seizure medication, at that point this patient needs to have additional workup, needs to see an epileptologist. This is the drug-resistant epilepsy patient, right? So unfortunately, this is also the vulnerable group of our patients who have a higher risk for injuries. They have a high psychosocial difficulties, and they have significant reduced quality of life. I just summarize briefly what they are all dealing, and there are just some of these sides. So injuries, a disability, they have mental conditions. About 40% of these patients will feel like they have a depression. They are challenged by this condition. So they have to seek some help and talk about this. There is still a huge amount of stigma about this condition. A lot of people don't want to hear it, don't understand it. So there is a lot of barriers that they have to face. There is a higher suicidal risk, about 3 times higher in comparison to the controls. They are more likely to turn to alcohol and drugs, and they cannot drive, right? So they are having seizures, they cannot drive, so that already is impacting their life. So it is important that this is a patient group, patient population that gets addressed fast and early. Because believe it or not, there is still a delay of 10 to 20 years before these types of patients reach our epilepsy centers, right? There are so many years that things could have been done, that things could have been improved if you would have seen them earlier. So speak up and talk about this with your physician. Many have not even been to the epilepsy monitoring unit, have never been admitted for more than 5 days to look at their seizures. So this is number one thing to do, and that's where we start. An epilepsy monitoring unit is an admission to the hospital for at least 5 days, sometimes longer. And basically, what are we doing? First, we want to confirm this is epilepsy, because in many cases, patients will have episodes that look like seizures, but are not. And about 25% of this group will be misdiagnosed. They're taking medications for no good reason, so this is very important. In addition, we will know what type of seizures these patients are having, so we can guide them with a medication selection. In addition, we can start them on a pre-surgical workup, which hopefully at some point can actually make a big difference in their lives. So, diagnostic workup, I already mentioned. There is the MRI, the PET scan, neuropsychological, fMRIs. But in addition, we have been doing more. And now that we have the MEG, the magnetoencephalography, I would like to talk about that. That is an additional information on all these tests that we already have, and it can make a big difference. So let me run this through you. Very simple. This is not new. This has been out for many decades. And first time Dr. Cohen actually describes the first brain waves in 1968. So it has been there, it just was not yet ready. In 2006, there was a founded Society of the American Clinical MEG, and then they worked hard to come up with established clinical practice guidelines in 2011. The MEG is in many sites in the US, probably 25 of them clinically used. In California alone, we have 3. Which are clinically used, but also research. So it is started out with heavy research focused, and now in California we do a lot of clinical work with that. So it is important to know. So one of the oldest one is at UCSF with the CTF system. I think they have it since 2003, so many years. They're doing a lot of great clinical work and also research. UC San Diego has the Elekta system. And we at Kaiser Permanente do have the MEG by Megin in Redwood City in the neuroscience department. So to lead you through this is how the machine looks like. Showing you a sitting someone, probably not a real patient, and this is how the patients in a sitting position would be positioned. The MEG is not an imaging scan. So it is not going to show you a brain like the MRI does. What it does is it goes into the smallest magnetic fields, records them, and then it shows it up after analysis as a dipole. And that helps us. So we combine the MEG recording with the EEG, and we will get an amazing localization and identification tool. It is non-invasive, so we are not doing any injections, there is no radiation, there is no tight tube with a lot of noise and feeling claustrophobic. It's very simple and very calming. If you look at this picture, you can see this we call a door. We have the liquid helium there, and this is the important part. This is the helmet. This helmet has sensors, 306 sensors. This is how they look like on this image from Megin. So these sensors basically go into the small little neuron activity, record what's happening there, similar to an EEG, just much more detailed because it is not filtered by bone or tissue like the EEG is, and then it records spontaneous data as well as some evoked responses. This is how it looks like in an EEG. This is the EEG picture, a standard international system of 10-20, 16 to 25 electrodes depending, and then the MEG with 306 sensors in the helmet. The MEG and EEG are done simultaneously. So when you go into that room, you are placed on this in this machine. You have an EEG on your head, and it's recording both tangential, which is much better on the MEG, as well as the radial sources. And in combination, they will add on additional information that might be very important for our patients. So this machine is very sensitive to any type of noises, right? So it needs to be placed into a room. And this is called a magnetically shielded room. So it has very thick layers of metal walls, and this machine needs to be shielded from the environmental magnetic fields, and that's what this room does. So it's placed in there, and it looks like this. You can be in a laying position, which is preferred for our epilepsy patients, as well as in a sitting position if we do some functional mapping. It is, as you can see, there is a lot of light, it's quiet, and we prefer you fall asleep during this recording. So we designed a small patient instruction pamphlet, and basically what we are asking our patients is, 1, please come in sleep deprived, as you do for your EEGs. Do not change your medications, just keep them the same. Come in and we will prepare you. The test might take about 3 to 4 hours, so bring in some time. If needed, bring in your medications. Please try to avoid any type of caffeine because we do want you to fall asleep during that test. You will get a nice warm blanket and a pillow, and you can literally nap in there and enjoy it. And then at the end we will get you out. Now I would like to go to the small little steps that the patient needs to know of and probably is curious about. So before the patient even comes in, we actually test the sensors with a phantom. We check on the helium levels every day, and then we have a patient either with a cap, it has a 32 channel cap, or just a 10-20 system. We ask them to change, to go into an MEG compatible, either scrubs or any type of other options, and then basically we will start with the digitization. And the digitization puts a bunch of points on your head to try to align the scalp with the MRI and the MEG array. Okay, that's important for then putting these dipoles on top of the MRI. After this is done, the patient goes home and we will continue the work. We will do the data processing. And so which means we will look at the MRI of the patients, which we already have. We will average all the recording. We will filter a couple of noises and finally co-register and establish a hemisphere. And that's how it looks like. It takes about an hour. And then the last but very important part is to actually do the analysis, to actually look at the MEG and the EEG and find these epileptiform discharges, fit them, and localize them. So this is one of these common pages that we see with the MEG data analysis. As you can see, this on top is the MEG, and this down here is the EEG. It's, you can see slightly sharper on the MEG, which helps us to pull out these tangential sources, but also the radial sources that we see on the EEG are very helpful. And then we localize them. We analyze them with a standard analysis, and then we localize them. And here is the left temporal area that we localize these. Now, in summary, this is a newer device, a tool, an instrument, a diagnostic workup that we can provide to our epilepsy patients if everything else does not seem to give us the answers. But also, if we are planning on a pre-surgical workup, or we have questions in general of where are we going from here? Are these generalized onset zones? Are these focal onset zones? So this is an MEG that is minimal risk procedure, can be repeated as often as needed in any patients of any age. The MEG's recordings are not distorted by skin or scalp as the EEG does, but we combine them, MEG and EEG, and then superimpose them on the brain. Currently, there are 2 FDA-approved indications for it, which is epilepsy surgery and the tumor patients for pre-operative brain mapping. We do language, we do somatosensory evoked fields, so we can map these functions on the brain. At the end, I would like to bring you an example of a patient who is benefiting from this tool. And this is a 28-year-old young woman, and she has been having seizures since age 20. I met her in 2019. She has been having many seizures, has already been on 3 seizure medications, failed all of them, still continued to have seizures. Her seizures were very difficult to pinpoint, like she would zone out, not pass out, but she would not be there. She would have automatisms. She would do things repetitively. She would have some pulling on the face. And when she comes back, which is a couple of seconds later, she does not have any recollection that these episodes happened. So we did the same workup as with the first patient. We got the MRI, which showed some abnormal lesions in the left temporal tip as well as right heterotopia. We did an admission to the epilepsy monitoring unit and captured a bunch of seizures. In this case, the EEG was not very helpful. We still were having no clue where was it right or was it left? Where did it come from? Do they come from everywhere at the same time, from multiple locations? Where are they? Then we moved forward and we said we need to dig into this, and we did an electrode placement into the brain, and we captured multiple seizures, and all of them were coming from the right mesial structures, and some of them from the right heterotopia that she had on the MRI. So we offered her surgery, a minimal invasive surgery, the laser ablation. And we went into the brain and removed the mesial structures. The worry was about the neurocognitive deficits that she would have if you do a much bigger procedure. We knew this might or might not improve her seizure outcome, but this was the first, and she became seizure-free for at least a year. However, in May this year, she started to have auras again, and she is set to address that and to have more done so she can be seizure-free. So in this case, lid surgery was not successful. She still has more lesions in the brain, and we still are not quite clear where is the actual source. So we did the MEG, and the MEG was very, very helpful. We found that there is a dipole cluster within the heterotopia on the right side in the posterior temporal area. We captured these EEG-compatible MEG findings, and we localized them. And so at this point, this patient is on the schedule to get an RNS, and we will see how she does after that. But without the MEG, we would not be able to actually discover this. On the EEG alone, it did not give us the answers. So there are 10 common evidence-based MEG indications, and basically all 10 of these are saying do an MEG if you don't know where they're coming from, where these seizures are coming from, when the EEG is not helpful, when you have a large lesion on an MRI, and it could come from any area, if you have multiple lesions on the MRI, or if you have done a surgery and it's not helping. It is not made the patient seizure-free. And that should be always a goal. So in our world, we do want every single patient to become seizure-free, and we should work for that. We do want to remind that you should know to talk to your physician. If you fail the second medication, please ask what else can be done. Is there anything else besides medication that needs to be evaluated, diagnostic workup? See an epilepsy specialist or go to an epilepsy center to be evaluated. They are all accredited and have to do that every 2 years. So we do have more options, and I want you to be optimistic about it and talk to your physicians about it. All right? And these are my references, and thank you for listening. These are 2 pictures of a patient of mine with epilepsy, and it really struck me closely because this was her view on how it feels like when she comes to the emergency department. She meets someone who says, hey, you just had a seizure. A seizure, trying to describe, is a disruption of electrical communication between neurons. Epilepsy is a condition which is caused by the brain. And so her traumatic experience and being wheeled into the ER, not knowing where she is, everyone around her, someone in the background saying, get her to the ER. So that was her present to me. So it made a lasting impression. Thank you. Do you have any questions for me?
Hi, good morning.
Good morning.
My question is, my daughter struggles with catamenial epilepsy, so I'm wondering, would she be a good candidate prior to her cycle beginning for an EMU? That's something that's never been considered because she's currently taking 3 different anti-seizure meds and 2 rescue seizure meds, and I just think it's just heartbreaking just because, well, first of all, as a woman, no one wants a menstrual cycle, right?
It's hard enough, right? Yeah.
And then second of all, for her to have it because she's on her cycle, and from everything that I've read about CE, I'm hopeful that it will stop because next month she'll be 25. So from what I read, but of course you just never know. But it's complicated because her underlying diagnosis is Phelan-McDermott syndrome, and she's actually the only female in the Bay Area with this rare disorder. So, it's kind of challenging when you go to the ERs, you go to different places, and everybody's more intrigued about, oh, she has what? Instead of let's focus on her.
Yeah, let's focus on her, right? Yeah.
So, what do you suggest?
I would suggest to do the workup. Yes, an MEG is a good option for her. And usually you can actually schedule around the menstrual period. And it would be very helpful. Because it does look at your brain differently than an EEG does. It's an additional information which hasn't been looked at yet, and I don't know how the EEG looks like on her. But if there are epileptiform discharges, if these are focal seizures,
Oh my God! So she has focal seizure, tonic-clonic seizures, grand mal seizures, petite mal seizures. They vary, and but when the menstrual cycle comes, you just never know.
Now, have you tried the hormonal replacement therapies? Is that anything?
Her physician has not been willing to try that. We just now started the new CBD oil. In addition to that, she's currently taking Omni, and she's also taking Tegretol. And she used to take acetazolamide, but unfortunately she got a kidney stone as a result of that. But it's also difficult with her being nonverbal, being able to convey, what's going on. And even with her being diagnosed, it took over 5.5 years. When she got diagnosed, she was literally number 65. So everything has just been like a hurdle to try to, figure it out. And I'm concerned I'm trained to do it, and I'm glad that I know how to do it and what to do. But I never thought my daughter would be my patient.
Yeah.
So, I don't know. So I was just really hoping to hear, like, what do you recommend for children and adults? I know I shouldn't say children. She's 24, but she's 5.
Yeah, exactly.
I'm like, that's not very. But it's like, what would you recommend for someone with CE like her?
I would definitely talk to the physician. I hope this is an epileptologist you are seeing.
She's at Stanford.
Yeah. Then, talk to Stanford. I was trained at Stanford. They do good jobs, but push it further. Say, what else can I do? Like, is there something else? Talk about VNS. You might be right, and this gets better, but really, the data shows the catamenial epilepsy will get better, but the cycle doesn't stop, right? Our hormonal cycles will continue until menopause, pretty much. So, you're set for these seizures probably to continue, but there are other options. VNS is one of the good options. Maybe there is a value of some other devices, or maybe even the MEG will give you more clues. So I would continue as you're doing, and thank you for doing that. Thank you. Yeah.
I've had so many EEGs. I've had many in the hospital, never a 5-day one, just a 3-day one, and then of course the carry home the big heavy backpack with the computer and the 3-day one. And they were able to find seizure activity, some abnormal seizure activity on the 3-day one. And of course, never get any on the 1-hour one, and it's always been very frustrating to try to nail down exactly where from the brain the seizures are coming from. So my question, I guess, is with this kind of monitoring, do you get more, say you only have a few abnormalities show up on a regular EEG, or maybe none at all. With this, do you get more? Are you able to find more abnormalities?
That's exactly it. It's more because it looks at the brain from a different perspective. So it is more information, definitely. And even so, this is just maybe an hour or 2 of recording. Doesn't seem much, but usually there is so much activity going on that we can actually pull this into a specific, maybe giving you more information than you had from the EEGs so far. Yeah, so definitely worthwhile.
Thank you.
You're welcome. Thank you.